This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken only with prior written consent of the AARC. Copyright 2012, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services, and I welcome you to today's webcast on how quality care impacts payment, what you need to know. At the completion of this webcast, participants will be able to describe quality measures and their importance in today's delivery of healthcare services, explain how value-based purchasing can improve performance outcomes for hospitals and physicians, discuss the concept of bundled payments, and describe new payment models that have the potential to expand the role of respiratory therapists in the delivery of care. I am pleased to introduce our speaker for today's webcast, Anne-Marie Hummel. Anne-Marie is currently Director of Regulatory Affairs for the AARC and has served in that capacity since January 2008. Among other things, she's responsible for overseeing federal regulations that impact the respiratory care profession. Prior to joining the AARC, she was a healthcare consultant for 11 years, specializing in Medicare and Medicaid reimbursement, coverage, and coding issues. The AARC was one of her first clients. She is also a former senior manager at the Centers for Medicare and Medicaid Services, having retired from a 31-year career in the federal government in which she received numerous awards, among them the HHS Superior Performance Award. While at CMS, she directed the agency's regulatory management activities, national coverage process, and Medicare beneficiary education and outreach activities. Ms. Hummel discloses that she has no conflicts of interest related to this presentation. Anne-Marie, welcome to the program.
Thank you, Bill, and welcome everyone. I hope you'll find today's presentation useful. As Bill has suggested, we're going to talk about quality and how it impacts payment. But I thought in order to put things in perspective, it might be a good idea to sort of be able to get the big picture of where national healthcare expenditures have gone over the last few decades and where we're heading in the future. So to do that, we look back at the years between 1960 and 1993. And during this period of time, national health expenditure rate of growth increased fairly rapidly at 11.2%. And what that translates to is from 1960, almost $28 billion to $921.3 billion in 1993. Now, keep in mind that during that period of time, the Medicare program was enacted in 1965. So a lot of the increase in expenditures over that time, I'm sure, was due to the Medicare program. Then we came to sort of a growth trend that subsided between 1993 and 1999. In fact, the rate of growth decreased to about 5.2%. So if you look at that relative to the 11.2, that was about half of what it had been. But most important, in the years between 2009 and 2010, it really slowed down. The growth rate was 3.8% in 2009 and 3.9% in 2010. And part of the slower growth rate was due to the fact that payments to Medicare Advantage plans were decreased, and also there was a slower growth in Medicare spending overall. Now we come to sort of current events, and as you may or may not know, the CMS actuaries generally do projections in 10-year time frames. So the spending rate between 2010 and 2020 is now projected to be around 5.8%. What this really, I think the importance of this is to show that right here, it's going to become 19.8% of the gross domestic product by 2020, which is a little bit more than a 2% increase from 2009. However, if we go back up in these years, as I've talked before, the rate of increase was only 5.7%. So quite a bit of difference when we're looking at 19.8 in the future. That, of course, translates into $4.6 trillion in 2020, which is up from $2.5 trillion in 2009. If we want to look at that by the type of services and how much spending has increased, let's take a look at hospitals. Their rate of increase in spending went up 4.9% in 2010, which amounted to $814 billion. However, physician spending increased only 2.5% at $515 billion. But the interesting thing about this growth rate was the fact that it actually was slower than the previous year, which was at about 3.3%. And part of the reason for that was a drop in physician utilization and a drop in visits to physicians. And interestingly enough, it was also because there was a less severe flu season. So that can have an impact, as you can see. With respect to other professional services, these include, for example, physical therapy, chiropractic services, mental health, all of the other distinct benefits that are provided in the Medicare statute. Spending for those services increased 3.6% to $68.4 billion. And also, for these services, even though there was an increase, it was slightly less than 2009, which was at 3.8%. The big impact is going to come, however, with Medicare beneficiaries. So let's take a look right here. We've gone from 48.8 million beneficiaries in 2011 to a projection next year of 52 million. So that on the surface doesn't seem like a major increase. But let's come up here and look at what's going to happen in 2013. The number of Medicare beneficiaries are expected to increase to 80 million. And that's actually 32 million more than we have right now. And of course we know that a lot of that is due to the aging of the baby boomers into the system. So let's go over here and see what that means in dollars. Medicare expenditures are going to increase from $523 billion in 2010 to $932 billion in 2020. Now, keep note, however, that that's just 2020. 10 more years with all these extra Medicare beneficiaries aging in, I'm sure we're going to hit over the $1 trillion mark. If you look here at the average benefit payment for beneficiaries in 2011, it was $12,042, and that includes all of Part A, B, and prescription drug expenditures. But when you think about that number, and you look at, for example, patients with chronic obstructive pulmonary disease, we know that COPD patients, on average, cost a lot more than the average Medicare beneficiary. So you can imagine where these dollars are going in the future. I thought this was sort of an interesting breakout of the Medicare, of the healthcare dollar, and where all of the dollar goes. This is from the U.S. Treasury Department. You can see over here that Medicare and Medicaid together total about 37 cents of the dollar, with private health insurance coming in second at almost 32 cents, and other health care programs at 13 cents. So we know that the federal programs account for a lot of money. In fact, in 2012, between Medicare and Medicaid, the outlays were $732 billion. Sometimes it's hard to talk about dollars in such large amounts, particularly as we're getting into the trillions. So what we can do about it? What can we do about it? Well, I thought this cartoon was sort of interesting. It appeared in the Washington Post not too long ago, and it sort of suggested that we could contain health insurance costs if we simply let our coworkers diagnose us by the information that they got on the internet. Well, as you can imagine, we all know that that is not going to work. So we have to look at things that we know will make a difference. And what does that really involve? You have to get used to the fact that there is a new paradigm in healthcare. And when I say that, I'm talking primarily about the Medicare program. But as you know, the Medicare program is the model for all other third-party and private payers. So it has obviously a significant influence in how delivery of care is provided. No longer can we afford to keep the status quo that have been in the past with fragmented care and payment for multiple services. So what the Affordable Care Act has done is establish a national strategy to improve healthcare quality. And what that means is that the Department of Health and Human Services is coming up with a plan that's going to focus on 6 priorities to improve quality health care. One of them will be safer care, and as you know, in the past there's been a lot of emphasis on reducing hospital-acquired conditions and infections, and now of course we have preventing excessive readmissions for certain conditions. We want to involve patients and their families and caregivers in helping to manage their disease better and making sure that they're informed and can play an active role in their care. Another one of the priorities is effective coordination and communication. We know now that there are a lot of new programs that emphasize teamwork and working across different care settings. Also prevention and treating practices that are leading causes of mortality. We know COPD is the 3rd leading cause of death. And so smoking cessation will be an important part from a preventive strategy as part of this improved healthcare plan. And last, working with communities and making care affordable for all. And as I get into the presentation further, you'll see how some of all of these come into play. Linking payment to quality outcomes and pay for performance is not new. It's been around for a long time, and it is now really the status quo, if you will. And what that involves is, how do people know whether their outcomes are good? They have to report quality measures. In the past, it started with the hospital, inpatient hospital system, and now multiple providers are going to have to reporting quality measures, and that's really what we're going to talk about today. The Accountable Care Act also created a new center in CMS called the Center for Innovation, and their primary job is to develop payment care models that coordinate among different providers and provide better outcomes, and of course at lower costs, because that's really what it's all about. So in order to understand what we're going to talk about today, we have to know what a quality measure is. Well, if you look at the dictionary, the definition is a standard. It's a basis for comparison, a reference point against which other things can be evaluated. But how do you really know what that is, and how do you translate it into actual work? Well, if you look at the patient's record, for example, you can use operational processes that have been converted into rates or percentages or time even to show how well you're taking care of the patient. And all of this will become very evident as we go through some of the other slides here. These are the types of measure domains that CMS requires many of their providers to report. And when I say domains, you'll see how these align with the movement to improve the nation's health delivery system and all of these new innovative payment models that we're going to be talking about. They are not in any particular order of prevalence or preference, simply that's the way I put them together. So many of these measures, however, are endorsed by the National Quality Forum, and in today's healthcare system, they've become a common point of reference among providers. So if you talk about them, most people in the healthcare field are going to know what you're talking about. The first domain is clinical process and effectiveness. And this is pretty obvious because it really deals with outcomes that are based on evidence and clinical practice guidelines. So in other words, these measures are going to show whether the steps that are proven to benefit patients, if they followed, really have made a difference. Outcomes, that's pretty simple. We know that it's the actual results of care. And one of the ways that these measures report outcomes will be mortality rates. Patient, family, and family engagement is the quality of care delivered to patients. Well, these measures actually emphasize the importance of collecting patient data on how well they believe they have received care from both their physicians and their hospitals and other providers. And it's collected through formal survey systems, and eventually will be reported on some of the CMS websites that compare hospitals and nursing home care and patient experience with those. Patient safety is not a new idea, because obviously it aims to reduce harm and burden of illness, but we've been looking at this for quite some time because hospitals have been reporting measures for reducing hospital-acquired conditions, as mentioned before, and also particularly with respect to the new hospital readmissions program. Care coordination. This will be a big one, and as I talk through, I'm sure you've heard of accountable care organizations. There are a lot of other new pilot and demonstration programs that get folks together across care settings to work together in a team concept, and basically so that the right hand knows what the left hand is doing. This is a major way to prevent this continued fragmented care that's existed in the past. Population and public health, which is improving the health of the population served. And this sort of gets to what CMS refers to at risk. So if you look at large groups of the population of patients that have, for example, diabetes, obesity, heart disease, and COPD, these measures are aimed at addressing the population as a whole, not the individual patients. And a lot of this will be factored into adhering to medical protocols and other types of guidelines. The efficient use of resources. Everything's about outcomes and reducing errors, it seems. But one of the ways CMS is looking to use resources more efficiently is to look at an entire episode of care for a beneficiary. In fact, when regulations were proposed for this new value-based purchasing program, they were considering looking at all Medicare Part A and Part B payments, not only from 3 days prior to a patient being admitted to a hospital, but anywhere from 30 to 90 days after they got out of the hospital. This has not gone into effect yet, but I think we're going to see this in the future. This last one is a repeat of the previous slide. I was so engrossed in making these look cute and consistent, I didn't realize I'd already put this one on the other, so we can ignore that.
Anne-Marie, this is Bill. Could you move your slider bar for the speaker? It's right beside, it's at the bottom there. Could you move it over just a little bit to the right? Make your voice just a little bit louder.
Oh, I'm sorry.
Okay.
At the bottom here?
Yeah. You see where the on-off toggle switch is for the microphone? Just to the right of that, there's a speaker.
Is this better?
Yes.
Is that a little better, or is that too much?
Yes, that's better. That's fine. Thank you.
Okay. All right. So we've gone through the measured domains. Well, the Accountable Care Act created a number of new programs and new opportunities that I think will be exciting for respiratory therapists, particularly as some of these become more useful across the nation and not just as a pilot phase. Clearly, you're all familiar with Hospital Readmissions Reduction Program by now, and we'll talk a little bit about that if you haven't listened to some of the other webinars that have taken place. I'm not sure how familiar you are with value-based purchasing, but this is an important thing for those of you who work in the hospital setting. And it also is going to phase over to physician quality reporting and physician services as well. And then, of course, there's a whole bunch of these new pilot programs. And we're going to go through each one of these, so I'm not going to repeat them right now. Let's talk about hospital readmissions. There are some really good presentations that have been presented before this one, and it's sort of a disadvantage being at the end of the year. So if you haven't listened to them, I urge you to do so. Cheryl Orr and Greg Spratt have a couple of really good ones, and Cheryl in particular, because she provides a lot of information for respiratory therapists about how you can get involved in helping your hospital. I'm a policy person, so I'm probably not the best one to advise you, so I encourage you to listen. But if you don't know anything about hospital readmissions, I'll go through the basic provisions quickly. As you know, 30 days, hospitals are going to be penalized if they have access readmissions within 30 days of discharge. Now, the program has already started. CMS already knows what hospitals are going to be dinged. But what you may not know is in a study that Steve Jenks did of about 11,000 plus Medicare beneficiaries, and Steve used to work in the old HICFA days when I was there, COPD and pneumonia have the second and third highest rates of readmission after 30 days. It's probably not surprising, but the rate is about 23% to 21% respectively. The payment penalties will vary depending upon from the first year into later years. It's going to start with a 1% maximum penalty, which has kicked in now, it's beginning in October. And so if hospitals find themselves at sort of the top of the penalty mark now, I think it's safe to say that in the second year they're probably going to get an increased penalty of up to 2%. The good thing is, if there is a good thing about this, is that there is a maximum cap on the penalty at 3%, and that kicks in 2015 and for the years beyond. Now, what you might not be aware of is it's not just about any readmission. There's some thresholds and some data that are used to decide whether or not hospitals meet that excessive rate. They look at 3 years of discharge data, but the key is that they have to have a minimum of 25 heart failure, heart attack, or pneumonia cases that are factored into the ratio. Now, it's probably clear to say that hospitals have a minimum of 25 cases, so pretty much that's going to involve anybody who comes into the hospital with these conditions. COPD is going to be probably added in 2015. That's the first year that the Accountable Care Act allows for expansion, because right now these three conditions, as you see down at the bottom, are the only ones that are going to be tracked. What you may not know also is that there are 2 quality measures assigned to pneumonia cases as part of this readmissions program. And they involve blood cultures performed in the emergency department prior to the initial antibiotic received in the hospital, and also the initial antibiotic selection for community-acquired pneumonia in the immunocompetent patient. So again, certain thresholds have to apply. This is just to show you that all of these ICD-9 codes will be part of the diagnoses that will go into this reduction program. Some of these data you've probably already heard of. The Kaiser Health Group has analyzed the Medicare data files and has determined that over 2,000 hospitals are going to be penalized this first year for readmissions. That seems like a lot, but if you look here, there are only 307 hospitals that are actually going to have their Medicare payments reduced by the maximum penalty of 1%. So in the big scheme of things, that really doesn't seem like a lot of hospitals. In fact, CMS says that they only expect to recoup about $300 million in the first year. And if you go back and you think about the billions of dollars that I've talked about before in Medicare spending, $300 million really doesn't amount to a lot of money. However, we do know that hospitals, regardless of how much payment reduction they're going to get, are not going to like it, and this is going to be a big thing for them, especially when you take into account the fact that 2 million Medicare beneficiaries return to the hospital within a month of discharge. One thing I thought would be interesting to show you, and if you are a member of the management section, I think Bill Dubs has made folks aware of this report. I'm going to highlight down here at the bottom because I'm not sure, it's a pretty long link. I encourage you to go to kaiserhealthnews.org and find your hospital, because one of the ways you can help is to get an idea of how well they're performing. If you look here, I just sort of did a snippet of Alabama. If you look at Alabama here, you can see up and down, in fact, none of their hospitals have the 1% maximum penalty here. And even the ones that I picked out, which was at random, are all pretty much under the 0.5% mark. However, if you go over here to Mississippi, let's look at theirs. Here, you can see quite a few are already at the 1% mark, which means that they've got a lot of work to do. And even those that aren't at the top penalty are still pretty high, 0.8% here and close to the halfway mark. So I think you'll find it interesting if you look for your hospital. The report is by region, by individual hospital, and also by state. So let's look a little bit at the state tallies. I tried to look at hospitals that pretty much had the same number of hospitals being evaluated. So if you take Colorado, Arkansas, and Washington, they're pretty comparable. And yet, if you look over here at their reduction penalty, it varies. It's not significant, although Arkansas is just about at 0.5%. But when you come down here then and you look at the states that have a lot of hospitals being evaluated, it's interesting because even their penalties are pretty low compared to the total number of hospitals. In fact, this analysis that was done by Kaiser indicated that Idaho happens to be the only state where there are actually no hospitals being penalized. So if you work in Idaho, you're doing a really good job. And also, if you are in Utah, Vermont, South Dakota, or Wyoming, they also have the lowest average in those states for penalties. So again, you're doing a good job if you're in those areas. There have been a lot of suggestions about how hospitals can work to reduce their readmissions. And again, on the webinars, there are a lot of suggestions. Even as respiratory therapists listening to this presentation, I'm sure you're already thinking about them. But I wanted to point out particularly what the Medicare Payment Advisory Committee recommends, because this is where it all started with their recommendations when this program was created. First of all, we want to identify the population at risk. Well, we already know what that is. We're going to look at heart attack, heart failure, and pneumonia. And that was already set actually in the statute. But what's important here is to try and reduce hospital complications. The Agency for Healthcare Research and Quality found out that if a person was admitted and had some kind of severe event while they were in the hospital, for example, some complication from anesthesia, or a hemorrhage, or an infection, or even acute respiratory failure, that their chances were more than double that they would be readmitted once they were discharged. improving transitions once a patient gets out of the hospital. And this is where I think there's going to be a lot more influence over time with respiratory therapists getting involved, particularly for their pulmonary patients. Because it's very important before the patient leaves the hospital that they receive the education and training on their inhalers, that they have chronic disease management, self-management skills so that they learn how to prevent exacerbations once they go home. And last, better communication once you're outside the hospital. Even though it's going to be up to the doctor or the skilled nursing facility or whatever facility the person goes to or home once they get out of the hospital, they're the ones that are supposed to keep them from being readmitted. A lot of it is based on how well the hospital discharge planning process works and how much information those other providers have about the care. So keep that in mind. I'm now going to switch over to value-based purchasing because this is another hospital-based program where I think respiratory therapists can certainly make sure that the performance of their hospitals is at the top of the scale. This is a program that rewards hospitals for high-quality, safe care for patients. And it became effective in October, as did the readmissions program. So, not surprisingly, it's going to pay hospitals for better value, better outcomes, and innovations. And as you know, the typical payment over the past years has been for the volume of services, not so much for the quality. So think about it like a report card. If you got a good report card, if your hospital gets one, then they're going to get more money. And that's going to be good for everybody, not to mention the fact that the patient is going to benefit. But there are two things to keep in mind here. There are two factors that are going to be taken into account in determining whether the hospital gets this incentive payment. First of all, it's how well they perform compared to other hospitals across the country. But it's not just how well they perform nationwide, it's also how well they perform and improve their own performance within their own hospital setting. So CMS is going to award, it's on a point scale from 1 to 10. And you're going to get points, achievement of points, if you do well against other hospitals. And you're going to get improvement of points if you do better in your own hospital. And depending upon what that score translates to, you're going to get an incentive payment. Again, there are quality measures that are going to be involved, and we're going to talk about those in a minute. So it boils down to the fact that CMS is finally going to get value for their money. And what the Accountable Care Act does is it extends this value-based purchasing to other providers. So we're going to see this for skilled nursing facilities and home health agencies pretty soon, if not now, and particularly for physicians. And we're going to talk about that in a few minutes. The funding pool for this bonus comes from a reduction in what CMS would pay for a discharge in the absence of this program. So it basically comes out to a 1% reduction in the base DRG payment to the hospital for that particular discharge starting next year, and it increases to 1.2% in FY14 and up to 2%. Again, there's a maximum percentage, so that's good because we don't want hospitals getting too much money. Same kind of conditions are going to be tracked that were in the hospital readmissions program. However, we're going to have some new things here, surgical care and hospital-acquired conditions. There are no respiratory conditions. VAP, in fact, was considered a long time ago for hospital-acquired conditions, but CMS has not put it on the list, and it may come back on in the future. In 2014, they are going to add mortality for the 3 conditions that are being tracked. And the same quality measures I told you about previously, blood cultures and initial antibiotics are going to be the same for this program. I stole because it's a visual slide, really. You don't have to read all this stuff. Here's pneumonia over here. These are all these clinical process care measures I talked about at the beginning. It's one of the domains. These involve some of the surgical procedures. But what they're also going to evaluate are patient experiences. And this is where the survey comes in. And this is where respiratory therapists may be evaluated by the patients they treat, particularly with respect to staff responsiveness and medicine communication and hopefully discharge information, because it's about time that respiratory therapists were more involved, particularly for their pulmonary patients. But what you see here is how they're going to split up the ratio in coming up with the performance. 70% for these clinical processes and 30% for patient care. Now, when we get to 2014, it's going to change a little bit, because now we're going to have mortality measures coming in. So you can see here where before we had 70% for clinical process, it's now going to go down to 45%, because 25% of these measures are going to be counted for outcomes. Another little tidbit of information: the Joint Commission does an annual report every year on how well hospitals do on quality measures, and there are 620 top performers. Here's another chance for you to look for your hospital. This particular snippet is basically from California, and as you can see here, there are pneumonia. There's pneumonia measures, but also there's some children's asthma measures. And just because these are all blank doesn't necessarily mean that they're not doing well. It just may be that it's not one of the measures that are being tracked by that hospital. The link here is below. It's pretty easy to find, and so another opportunity for you to see how well you and your hospital are doing. This whole value-based modifier and purchasing concept is also going to be applied to physicians, and there's going to be a lot more improvement in the physician quality reporting system, because it's going to be mandatory now. This, in fact, involves both individual physicians and group practices, and as compared to everything else, it's about quality versus cost. The value-based modifier, however, isn't going to become effective until January of 2015, and it's going to be phased in over time. So it eventually will become effective completely in 2017. So what does that really mean? Here, I think, is a real advantage for respiratory therapists, because unlike some of the actual hospital reporting mechanisms, physicians are going to be involved much more in measures that are respiratory related. For the first time, this is going to come up in 2015, spirometry testing to diagnose COPD is going to be a measure. And we know how important that is, because there are so many millions of patients that have the disease and have never been diagnosed. That an evaluation, spirometry evaluation, has been documented in their file, or that they meet the criteria to have bronchodilator therapy, are also measures. And then there are group measures. We'll talk about those, and I'll show you what that looks like in a minute. For asthma, sleep apnea, smoking cessation, and even for COPD hospital admissions. And keep in mind, this is not readmissions. This is an admission to the hospital based on a certain percentage of patients that the physician or group physicians take care of. With respect to incentives, this is both a plus and a minus program. If physicians produce quality measures and improve care, they could get a 0.5% increase in their fee schedule. But if they decide not to report, or they're not successful in improving outcomes, they could get a reduction of 1.5%. And that's off of the fee schedule amount for whatever that particular service would be. With respect to the value-based modifier, when it becomes effective, the payment reduction could be as much as 1%. This is a very complicated program. There are a lot of measures, over 100 measures that are going to be evaluated, but the physicians don't have to report all of them, thank goodness for them. And it also depends on whether they're in a registry or whether they submit administrative claims, because, for example, if they were reporting through a registry, they only have to report 3 quality measures, and for at least 80% of the patients that they're seeing. So just because there's a lot of respiratory measures up here doesn't mean necessarily that all of those are going to have to be reported by the physician, so just keep that in mind. Here's what measures actually look like. If you've never seen these and aren't familiar with them, I'm not going to read these or go through a lot of them. You can sort of read them yourself. But you can see these are the ones I talked about with spirometry evaluation and bronchodilator therapy. And the asthma one is actually for patients aged 5 through 50 years with a diagnosis of persistent asthma and at least 1 medical encounter. Some more of them involve patients that had at least were evaluated at least once. There's children with upper respiratory infections, and tobacco screening. And of course, the interesting thing here is it looks at exposure to secondhand smoke within their home environment at least once during the year. I'm just going to run through the groups. Basically, it is what it says. They take all these individual measures and they group them into categories. So we've got all these asthma ones, which are pretty much what I've just talked about from individual measures. With respect to COPD, this also includes flu shots and vaccinations for pneumonia and tobacco screening. Flu and pneumococcal vaccine were actually included early on in some of these in the value-based program, but were dropped at the end, so that only 2 of those pneumonia measures are being accounted for. And here's sleep apnea. So this, again, is where respiratory therapists can play a role, because this is going to look at measures that assess their symptoms, how bad the severity is at their initial diagnosis, whether they get therapy through CPAP or RAD, and whether they actually adhere to the PEP, which is also, as you know, a very important aspect, because if they don't adhere to it, the outcomes are not going to be improved. Now we're going to talk about accountable care. We've been through this a lot. Coordinated care, chronically ill patients get the right care at the right time. If you do a good job, you're going to save. You're going to get money and share in the savings. So I'm not going to spend a lot of time going through that. But what you may not know is that there are actually 3 types of programs. The Medicare Shared Program is for Medicare beneficiaries who are in fee-for-service. There are about 100 of these programs right now. And basically, Medicare will look at what it would have cost the program for both Part A and Part B in the absence of having an ACO, and how well the ACOs do against that benchmark. The Pioneer ACO model is one that actually awards folks in this model a little bit more in terms of savings, but they have a bigger risk. And it's because they've been around for a long time, even before the Medicare program started. The one in the Accountable Care Act required it. The advanced payment model, this is for smaller ACOs and ones that basically are in rural areas or serving an underserved population, and there are about 20 of those here. Again, the concept of the program is you can share in the savings, but you also have to assume the risks if you don't produce care that lowers costs. So you have a choice. The model allows programs to have no risk in the first year, but it's a 3-year program, so after that they get the buy for the first year, they have to assume the loss in the second. One key thing to keep in mind is that there are 4 quality measure domains. We've talked about the domains: patient care, patient and caregiver experience, care coordination, preventive health, and at-risk population. And here's where I mentioned that COPD had been included, but at the last minute was changed because CMS wanted to provide more incentives for folks to sign up as an ACO. Again, just to look at same kind of measures, I'm not going to go through these, but there is a COPD or asthma admissions measure based on assigned beneficiaries, 1,000 assigned beneficiaries who may have had a diagnosis of either COPD or asthma. This is a new program, Bundled Payments. This actually starts in January, and I'm not sure, it hasn't gotten a lot of publicity because hospital readmissions have been at the forefront of the news recently. But you can see why, if you look at today's care or previous care, why this might be needed. As we've talked about before, the program now, particularly fee-for-service, is designed to really have a fragmented care. There's no relationship between providers. There's no coordination for the most part. And Medicare continues to make separate payments for a single illness or course of treatment. So for example, if you have surgery, there are lots of claims that come about as a result of that. Now, it's just going to be one bundle payment for all the services that are involved. Typical, the system doesn't really provide an incentive right now to coordinate care or to look at it from an episode, as I've talked about before. And again, same mantra, this is designed to improve health care, improve quality, and lower costs. The key components of this program, it's voluntary, but however, and it's only going to be piloted in a few states to start, but if it does well, this could be something that we're going to see on a national level sometime in the future. Multiple services are going to be involved, and it is going to deal with an episode of care from start to finish. It's going to bring all these types of providers together, which don't normally work together, both in and outside of the institutional setting. But the key element here is that those who apply for this grant or pilot, if you will, they get to work with CMS to set the amount of payment for that defined set of care. And they also get to pick the type of condition that they want to track. For example, it could be COPD. It might be congestive heart failure. It could be obesity. It could be a number of things. And so what CMS will do is basically figure out what it would cost to provide the care normally, and then maybe set a target discount amount so that that provides the incentive for the program to save money. And that's what it's all about, saving money. I'm not going to go into a lot of detail about this particular slide. It's basically to show you that there are 4 models. And if you look across the top here, one model is just for inpatient services. Another one combines both inpatient and post-discharge services. And the third is just post-discharge. And these 3 models are basically the ones I was talking about, where there's a retrospective target amount. The 4th model is like prospective payment. It's going to be a prospective amount that they're going to get up front, and this is for only inpatient stays. But the key here is that there are a variety of services that will be part of this bundle payment. It will be not only about inpatient and physician services and related post-acute care, but it also is going to relate to readmissions. Now you might ask, well, how does that differ from hospital readmissions that we talked about earlier? They're 2 different programs. So keep in mind, these readmissions have nothing to do with the other that we talked about. Hospitals are not going to be, receive less money because of these. This is a coordinated effort that deals with a group of providers. Again, as I mentioned, the hospitals can choose their own conditions that they want to cover. Some of these other lesser-known pilots I wanted to bring to your attention today because I just think that overall you need to get an idea of how many things are going on and where respiratory therapists can fit in the big scheme of things in the future. This is a community-based care transition. Again, has a lot of the same goals as all these other programs, so I'm not going to go into that. But the difference here is that it involves hospitals with high readmission rates partnering with community-based organizations. And that's sort of the different part here, the community-based organizations. In fact, I think CMS is going to give some preference to the Administration on Aging grantees to partner with these hospitals and then also those that serve medically underserved populations in smaller rural communities. It's a 5-year program, and there are 30 participants right now, but it's going to cover 185,000 plus beneficiaries in 21 states. So it's pretty broadly based. I wanted to go into a little bit more detail about this particular one because the care coordination services, they have to have at least one of these at the time this program starts. So the care transition has to begin no later than 24 hours after discharge. Education is key, but the key to the education here is that based on cultural and language differences, it's imperative that the patient be able to understand the education that they're getting about their health when they leave the hospital. This, of course, involves timely interactions between the patients and the acute care providers and outpatient providers that they are going to be involved with once they leave the hospital. But most important, and this is where I think respiratory therapists play a role, there's going to be patient-centered self-management information specific to the beneficiary's condition. So your role, of course, is to prepare them for what they need to do to prevent their exacerbations once they leave the hospital. And the better educated and the more chronic disease management services that can be provided, the better the patient's going to be in the long run. And last, they have to have a comprehensive medication review. This has a similar name, so comprehensive primary care should not be confused with the one we've just talked about, which is community-based care. This one differs a little bit because now we're going to involve state insurance plans and primary care providers. Even Medicaid, I think, to some extent, is going to be involved in this. The other unique thing about this type of demonstration is that CMS is going to pay the primary care doctors a monthly fee to take care of the beneficiary. And it's going to average about $20 a month. That might not seem like a lot, but it is an incentive to coordinate this care. And it is, again, primary care. This is the focus is on primary care here. So as you can see, there are 500 primary care practices that have already been involved, which take into account about 200,000 plus providers in 7 localities. And this is expected to reach 300,000 Medicare beneficiaries over time. Independence at home demonstration. You've probably heard of this. It's a new model, different in other respects because this is all about the physician and the perhaps nurse practitioner being in the home. That's where the primary care would be provided. It's designed to improve health outcomes and reduce payments. And the key here is multiple chronic diseases. So COPD, again, could be one of these. And that's why it's important to listen to Greg and others' webinar on hospital-to-home initiative that AARC has going on. The advantage of this type of program is that it's going to allow the home care providers to spend more time with the patient and to be able to assess them in their own environment. Teamwork is important, and while it specifically will include physician assistants and pharmacists and social workers, I'm sure respiratory therapists will be a part of this team. Right now, there are about 15 independent practices and 3 consortia that are participating in this program, and they have to have a minimum of 200 beneficiaries to be eligible to participate. Patient-centered medical home, well, that might sound like the same thing as independence at home. This has another name. You might have heard it referred to as advanced primary practices. So it's a little bit more broadly based program. Same approach, utilizing a team effort, going to improve quality, coordinate health care. But one of the features here is that it's going to bring in federally qualified health care centers, which have not been part of the mix in some of these other coordinated projects. It'll still involve Medicaid and private health plans, but FQHCs, particularly because they can reach a broad-based arena, will be important. The emphasis is going to be on prevention, health information technology, care coordination, and shared decision-making. Another unique thing is while they're going to pay a management fee for high care beneficiaries, this is a little bit different from one I've talked about before because the monthly payment's going to depend on the complexity of the person's illness. Right now there are about 1,200 medical homes expected to serve about 900,000 Medicare beneficiaries. So what have we learned through all this? Well, healthcare costs are skyrocketing. 32 million beneficiaries are going to age into the program over the next 8 years. There's a new healthcare paradigm. Providers need to do a better job in providing quality care. There are lots of new innovative payment models that are being tested. So where do respiratory therapists fit in? As we've talked about throughout the presentation, there's a lot more emphasis now on respiratory issues, particularly COPD and asthma. That wasn't true in the past, and so I think a lot of new opportunities will result from that. Particularly because providers stand to gain or lose dollars, and because we know that respiratory therapists improve patient outcomes, this is where you can help your facility or your provider do the best job they can. One of the keys is that knowing your value, they might come looking for you and saying, we need your help, but please don't wait around for that. You need to get them ideas and plans and recommendations. So talk to your department and find out what's going on, because we know that being proactive, you can definitely make a difference. Because CMS's policy is going to focus on better care, and there's going to be a lot more emphasis on discharge planning. This is why I encourage you to listen to Cheryl Orr's presentation, because she really talks about how respiratory therapists can get involved here. I think this is going to be a key item as we move forward. And if you're not involved in the process now, particularly for your pulmonary patients, you need to make the case that you should be. Clearly we know nurses and social workers are the ones that primarily get involved, but you need to be as well. So seek out your department head and supervisor, talk to your peers, find out what your hospital's doing. Go back and look at some of these reports that I've given you on how well they're providing quality measures and what their readmission rates are, and be knowledgeable. Because remember, quality is the name of the game. With the Accountable Care Act, everyone's going to have to start having health insurance in 2014. And so that means that an estimated 30 million Americans are going to have access to care that haven't had it in the past. COPD is still going to be the third leading cause of death. There's obviously a renewed focus on chronic diseases, and respiratory therapists are going to be needed to answer the call. So be informed, be there, and take action. Thank you.
Anne-Marie, I want to thank you for a tremendous presentation on the role of quality in the accountable or in the forthcoming healthcare system. It's really interesting how creative the government has gotten about getting the formerly segregated components of care to bring them together, all those that contribute to cost and quality, to try to increase quality and lower costs. We have gone a little bit longer than we had planned on today. I want to be respectful of your time as participants. I know there's a lot of information presented here. We will get this archive up as quickly as we can. And I want to thank all of you again for participating in the webcast program this year. Now, hang on just a second. For those of you that are watching this as a live presentation, please stay with us for the next brief pause for instructions on how to obtain your CRCE contact hour. And if you're watching this program as an archive, this concludes our presentation.